So good morning, everyone. Thank you very much for the selection of my abstract to present the primary endpoint results of Ibrutinib versus placebo in early stage CLL patients. Here are my disclosures. And as you know, the majority of CLL patients is diagnosed at an early stage. And so far, there has been no proven benefit of an early treatment intervention with chemo or chemoimmunotherapy in this subgroup of patients. Ibrutinib acts more specific on the B-cell compartment, is quite efficacious, and has a fair toxicity profile. So with this trial, the CLL-12 trial, we asked the question, do early-stage CLL patients with an increased risk of progression benefit from an early treatment intervention with Ibrutinib? And the risk of disease progression was measured by the German CLL study group score, a precursor version of the CLL-IPI score. And this included several laboratory, clinical, and genetic risk factors. So in this trial, treatment-naive, early-stage asymptomatic BNA patients were included and risk stratified according to the previously mentioned score. 152 patients had a low-risk profile and were automatically allocated to the observational arm, and they were not part of the primary endpoint analysis. The remaining 363 patients had an increased risk of disease progression, and they were randomized to receive either Ibrutinib or placebo. The very first patient was randomized in April 2014, and the last patient had just been recently randomized in February 2019. The median observation time of this trial is 31 months, and in this double-blinded placebo-controlled trial, the primary endpoint, event-free survival, is defined as time from randomization until symptomatic disease progression, new CLL treatment, or death. And the secondary endpoint also includes survival. So let's look at the baseline characteristics. In this trial, the median age was 64 years for both groups. The median ECOG performance status was quite good. It was 0 for both groups. And only 13 and 18 patients of each group had an increased comorbidity evaluated by an increased comorbidity index rating scale. In 6 and 7 patients, a 17p deletion was detected, and 70 patients of each arm had an unmutated IGHV status. TP53 mutation was observed in 14 and 13 patients of each arm. Beta-2 microglobulin levels were elevated in almost 8% of each arm, and thymidine kinase level elevation was observed in 3/4 of the patients. One cycle was defined as 28 days, and the median treatment duration was 21 and 18 cycles per arm. Since the last patients had been randomized just recently in February 2019, 10 patients of each arm have not yet started with treatment at the time point of the primary endpoint analysis. 17 and 13 patients refused treatment after they had been randomized, so they will not receive any treatment at all. And 34% of the Ibrutinib treated and 46% of the placebo-treated patients have discontinued treatment. And as expected, the primary reason for discontinuation were adverse events in the Ibrutinib group and progressive diseases in the placebo group. Thus, 185 patients remain on study drug. So let's look at the adverse events. Quite surprisingly, there was no difference in any grade adverse events observed in 95% of the patients of each arm. Additionally, adverse events of CTC grade 3 or higher did not differ significantly between both groups and were observed in 51 and 43% of the patients. In the Ibrutinib group, 77 patients had interrupted treatment due to an adverse event, and as expected, the primary reason for treatment interruptions were arrhythmias followed by bleeding events. At the time point of the endpoint analysis, 4 and 5 fatal adverse events had been documented for the here listed reasons, and the event of cardiac failure was related to Ibrutinib. Serious adverse events were documented in 40 and 39% of the patients, and the most common seen serious adverse events included infections, neoplasms, and cardiac disorders. And again, there were no significant differences between both groups. adverse events of clinical interest were defined as commonly ibrutinib-associated adverse events, and as expected, they were significantly higher in the ibrutinib group and affected almost 70% of the patients. The risk of bleeding was approximately 30% in the ibrutinib group, and the risk of bleeding of CTC grade 3 or higher was approximately 4%. AFib occurred in 21% of the ibrutinib-treated patients. Severe atrial fibrillation of CTC grade 3 or higher in almost 8% of the patients. Hypertensive disorders were documented in 12% of the ibrutinib-treated patients, and the rate of CTC grade 3 or higher hypertensive disorders were equal in both groups. Surprisingly, the rate of diarrhea and cardiac events other than AFib or hypertensive disorders did not differ significantly between both groups. So now let's look at the primary endpoint, and as already pointed out, event-free survival is defined as time from randomization until symptomatic progression, meaning that the patients did have to have a treatment indication according to the IWCLA guidelines. As expected, the event-free survival was significantly higher in the ibrutinib group, illustrated in blue, where only 18 events had been documented, compared to 55 events in the placebo group, where the median event-free survival was 48 months. Next, we also looked at the progression-free survival, and in comparison to the event-free survival here, the mere time to progressive disease with not necessarily a treatment indication was measured. And again, here the difference is a little bit more pronounced, and the event-free survival, the progression-free survival was not reached in the ibrutinib group, and was 15 months in the placebo group, with 101 documented PFS events. Then we also looked at the time to next treatment, and a total of 17 subsequent CLL treatments had been documented, and as you can see, the majority of patients received a chemo or chemoimmunotherapy followed by an ibrutinib-based regimen. And again, time to next treatment the median was not reached in either group, but it was significantly longer in the ibrutinib group. And as you can see, even 3 patients of the ibrutinib arm received an ibrutinib-based regimen, and this is due to the fact that the ibrutinib-associated lymphocytosis was misleadingly interpreted as progressive disease, and after at least 2 patients had been unblinded, the physicians decided to continue ibrutinib treatment. So, of course, one possible limitation of single-agent ibrutinib is the risk of clonal evolution and of drug resistance. The histologic transformation occurs typically during the early course of the ibrutinib treatment initiation, and the patient is also at risk of PTK or PICG2 mutations. And at this time point, we have no hint that there is an increased risk of at least a Richter transformation. Even on the contrary, the 2 observed Richter transformations occurred in the placebo group. And next, of course, we have to bear in mind that 34% of the ibrutinib-treated patients discontinued treatment early, and we have to see and evaluate how they will manage on the long term. And to answer the question that I initially addressed, whether or not patients benefit from an early intervention, this question can truly only be answered when the survival data is present. And the good part is this trial is powered for survival, but it's event-driven, and we can perform a survival analysis when 24 death events have been documented. And so far, we have 12 documented death cases for the here listed reasons. So with this, I would like to conclude that, as expected, ibrutinib improves event-free survival in early-stage CLL patients at increased risk of progression. A little bit surprisingly, there were no differences in most adverse events when compared to placebo. As expected, the ibrutinib-associated side effects were significantly more often in the ibrutinib-treated group and were the main reason for treatment discontinuation. And then finally, waiting on the survival data, we still recommend a watch and wait strategy for early-stage patients. And with this, I would like to thank a couple of people. I would like to thank the prime investigators and their patients, my team at the German CLL study group, Cologne and Ulm Laboratory, Janssen and particularly the Data Safety and Monitoring Board with Uli Jäger, Daniel Ketowski, Tadeusz Rubak, and Martin Helmich. And finally, my supporting people at the German CLL study group, whom I really look up to. And you, thank you very much for your attention, and Pete Hillman for the very outstanding organization of this IWCLL meeting here in this wonderful city of Edinburgh. Thank you.
Maybe time for one quick question.
Yeah, can I? Yeah, Petra, Arno Kater from Amsterdam.
There you go.
So very interesting data. The question is, one of the things you might want to prevent if you want to do this very early intervention is not only time to progression, but also prevention of infections. And since you see no difference in infections between the Ibrutinib and the placebo group, can you say, is that related to the timing? So is the most infections comes after 1 year when maybe IgG level, IgA levels drop, or is it early? To help maybe explaining why we don't see a difference and if we should maybe adapt this kind of protocols.
Well, thank you for this question. So at this time, there's really no difference between at least the serious rate of infections. We were exactly the same between both groups, and we did split it up with the different time frames, but I don't know it by heart right now because we didn't dive into the data deeper, but we will do it at least when we are going to publish the data, yes.
So with these infections, is there any signal indeed what was reported and discussed yesterday also about fungal infections?
No, actually there was no atypic infection. There were no fungal infection in the Ibrutinib arm. There were no PCPs. There were no cryptococcosis or whatsoever. So we didn't see it. So it seems at this time point that at least in early stage CLL patients, it does work quite well, and that we did not have an increased risk of those atypical, mostly fungal infections that had been previously reported.
Yeah. Very quick.
Okay, I'll try to be good. Hi, Petra. Stephen Mulligan from Sydney. Look, my concern about this study is that it really doesn't have a valid endpoint. So you've quoted as your primary endpoint essentially a couple of methods, i.e. EFS, PFS, that reflect disease progression, but that's in patients that are being treated versus patients that aren't being treated. In effectively, off a trial, patients that we wouldn't be treating at all. And secondly, that your overall survival signal, I fear, could be lost because unlike former eras where we've had chlorambucil versus watch and wait and fludarabine and FCR versus watch and wait, there wasn't really a major benefit that we had where we've got now, where we've got 3 major treatment classes of drugs, Ibrutinib, venetoclax, and still immunochemotherapy, and a survival signal on 158 patients is going to be lost.
Thank you very much for this question. So to answer your very first part, maybe you can stay a bit longer and join me to my talk after the morning break, because I'm going to talk about primary endpoints. And yes, definitely, we understand that event-free survival, of course, as expected, should be better whenever you do something and compared to do nothing. But again, as I told you, this trial has the number of patients and is powered for survival. So we will have the survival data in approximately, I guess, 2 years, so then we can definitely answer your question, and then we will see whether or not there's going to be a survival signal.
All right. Thank you, Petra.